Hello, I'm Dr. Keith Martin, the Executive Director of the Consortium of Universities for Global Health, and welcome to this an ongoing series of webinars by CUGH. One of the compelling challenges is to address the deficit in human resources across both biomedical and non-biomedical skill sets in low-resource countries. But this is, of course, an international challenge affecting every country in the world. We're in today to listen to a model that has worked exceptionally well, and we have two leading people involved in this to speak to this particular model on this webinar. The Toronto Addis Ababa academic collaboration is one that has worked exceptionally well in a very sensitive and effective manner to be able to build and sustain human resources in a low resource environment. I'm here today to introduce two leaders and two speakers in this particular collaboration. Dr. Brian Hodges is a professor in the Department of Psychiatry at the University of Toronto. He's Executive Vice President in the University Health Network and also the Chief Medical Officer at the University of Toronto Health Network. Dr. Hodges is a practicing psychiatrist and teacher, and his research focuses on assessment, competence, compassion, and the future of the health profession. Dr. Clare Payne is also a psychiatrist. She is an associate professor at the University of Toronto, the Department of Psychiatry. She's also the director of the Psychological Trauma Program at Mount Sinai Hospital in Toronto. And since 2003, she became the co-project director of what was then known as the Toronto Addis Ababa Psychiatry Project, but is now known as the Toronto Addis Ababa Academic Collaboration. So it's a great pleasure for me to introduce both of these speakers. Dr. Hodges is going to speak first, followed by Dr. Payne, and then we will open it up for questions from you. So get ready to submit your questions when you can. So Dr. Hodges, thank you very much for joining us today, and I'll turn the floor over to you.
Thank you very much, Keith. It's a great pleasure for Claire and I to be here today and for everyone joining us to tell you a little bit about the history and philosophy underpinning the Toronto Addis Ababa Academic Collaboration. I just wanted to call out as well our colleague Marcy Rose, who is the coordinator of the program. There's a huge team that makes this wonderful program possible. I'm going to speak in the first half about some of the underpinning concepts that we've evolved over the years in this now 16-year-old program, and a little bit of the literature about international partnerships. And in the second half, Claire will talk a bit more specifically about the challenges and opportunities that led to TAAAC and what we've accomplished. So to open, I want to talk a little bit about quality and effectiveness in international partnerships in general, and look at a few key issues here. The first is partnerships that touch on professional education, health professions in particular, the challenge of working between high and low income countries, and to be very open, I think, and honest about the fact that when we're working in these partnerships, the legacy of colonialism presents some very significant considerations. I also want to tell you a little bit of a story, because the Toronto Addis Ababa Academic Collaboration, although 15 or 16 years in this chapter, is part of a much longer story between Canada and Ethiopia. This is a picture of Father Lucien Matt, who was a Jesuit priest and educator, and he was actually engaged by the Emperor Haile Selassie of Ethiopia to help develop an education system. This is fairly remarkable, and I think we're doing some research on this. We believe because Haile Selassie attended the Alliance Française, the French education system, he undoubtedly had an admiration for the Jesuit system and the French educators. It's also quite possible that he didn't want to approach a colonial power at the time to help develop the education system. So in fact, the first Canadian-Ethiopian educational partnership was in the 1950s. This is a picture of Matt and Selassie together in 1961. In 1945, the first project was at the behest of the emperor to help develop the primary and secondary school system. And in 1954, the University College of Addis Ababa University today, was founded. And Lucien Matt was the first president of this university. This is a little anecdote, a footnote I love to tell, and I think it challenges our assumptions about these kind of partnerships. This is a picture of the residence in Canada, which is named after Lucien Matt. And in fact, The way this came into existence was following the work together of the Emperor and Lucian Mat. Emperor Haile Selassie gave $10,000 to Canada to help build this educational institution. So in fact, the first act of philanthropy between the countries of Ethiopia and Canada was from Ethiopia to Canada. So let's turn a bit to what quality means in building an international partnership. And I want to call out two discourses or two ways in which people talk about what it means to be engaged in an international partnership. The economic discourse is very powerful today. This is certainly true in our country, in Canada, and this is a discourse that speaks a lot about and focuses on efficiency, effectiveness, outcomes, and translates all of that into economic outputs. This is a very important framing for anything in the 21st century, and one very commonly used to talk about education. But in the TAAAC program, as it's evolved, we've wanted to emphasize another discourse, and that's what I would call the humanist or progressive discourse, which adds other criteria for outcome, those things that are related to human development and social change. Edward Deming, the famous founder of the idea of the quality movement, is a perfect example of the discourse that's being used in so many sectors, which is the economic discourse. This quote, costs go up and productivity goes down, quality is linked to design, engineering, et cetera, et cetera. This is the economic discourse. So I don't in any means wish to discount this. This is crucially important. But I'm going to contrast it in a moment with the other discourse. There is, however, an important economic relationship, and before we leave it, it's important to call this out. This is from The Economist magazine, and this is a graph of the return on investment, the average increase in earnings for each year of tertiary education. It's really striking. In all parts of the world, of course, higher education leads to better life outcomes, health outcomes, as well as economic outcomes. But I draw your attention to the Sub-Saharan Africa section at the top. The effect is extraordinarily significant. So for those people who are able to access a high quality tertiary education, higher education in Sub-Saharan Africa, the effect on their life and their economic outcome is enormous. But education, of course, is not a factory, and many of us in education we have some antibodies to always thinking about projects entirely in economic terms. So I'd introduce here as well. This is from the organization called Unite for Quality Education for a Better Education for a Better World, which is based in Belgium. And I think they tend to use, as we have often, the more progressive humanist discourse. And that is that quality education enables people to develop all of their attributes and skills for full human development and for the development of the society to which they belong. So that quality education is seen as a foundation for equity in society. And this is something that we think a lot about as we've developed the TAAAC project. Another page from The Economist along these lines is trying to suss out, as we all do in education systems, what are the most important factors in terms of high quality education. And this entire edition of The Economist, which looked at models around the world, made a really interesting point that in fact the number one factor that matters the most is the quality of teaching. So many factors affect the quality of education. I'm sitting in a wonderful school in Toronto right now where we do some excellent education. But when you go through various models of education, you discover that that central role of the education model and the teacher is critical. So this is from the Education Endowment Foundation in 2016, which is cited in the Economist article, and they talk about different factors. They break it down a little bit more. There are many other factors, of course, class size, resources, the access to technologies, etc. But the factors that are at the top are all related to the quality of teaching. And they said that effective teaching is the single most important factor contributing to achievement. Well, that being the case, when you're setting up an international education model, it then becomes critically important to think about who are the teachers and how do you select them and what is the quality of what they do. There's some literature on building sustainable quality education in Sub-Saharan Africa. It's not a literature as well developed as it might be, and something that our folks in the project, is particularly on the Addis side, are contributing to. This is a piece from EdQuality, and it's about a research program through a consortium that's been looking at education quality in low-income countries. And this is one of many examples of the models and philosophies that we've tried to learn a little bit about as we've developed this project that you'll hear about from Clare. One critical piece that emerges as soon as you look into the literature on education in Sub-Saharan Africa, all of Africa, all low-income countries, is the colonial legacy. Of course, Ethiopia is very proud of being one of the only countries in Africa that was never colonized. They were occupied by the Italians during the Second World War, but as our Ethiopian colleagues like to point out, most of Europe was also occupied during the Second World War. So that's not quite the same as colonialism. And yet, the obvious dominant effect of powerful Western Euro-American models in Africa is still a very, very important and powerful force. Guthrie talks about westernization disguised as, quote, better teaching. And one of the things I think we first encountered from the very first visit back in 2003 was the need for us to think through what exactly it was that we were developing. And immediately when you get into things like assessment and accreditation and quality, you start to hit up against the fact that most standards that people use are developed in high income and Western countries. Hawes and Stevens have a model about quality and talk about 3 strands of understanding what quality means in an international education project. Of course, efficiency in meeting the goals, but as well a relevance to the human environmental needs and conditions of the location in which the project is taking place. And something I love called something more. One of the very last slides I don't want to ruin the punchline, but Clare will introduce you to one of our graduates in the program who's now a dear friend and collaborator. But the something more is that we all know that there's something wonderful that happens in education that allows people to realize some potential that they may not have realized otherwise. And I think this is something to keep an eye on in a world that looks at hardcore metrics. Now, what about quality education in terms of African history and culture? This is tricky. And when we arrived, I think, on the scene in Ethiopia, we perhaps didn't think about this as much in the beginning as we might have. Now, we'll hear about it later, but program number 24 in TAAAC is actually a Master's of Education. And that program was started about 2 or 3 years ago. And one of the wonderful things there was the synergies with the Faculty of Education, but also scholars in that program digging into the literature on traditional education in the country of Ethiopia. I think, though, to go to the bottom line, it's important to consider that quality education must include theory and practice that's based on African history and culture. So what is quality in health professions education? Here I would draw on an article that's widely cited. This is in the international space, I think one of the most read articles from the Lancet. It's from the Education Commission on Health Professions for the 21st Century. And it talks about how health professions education, medical education in particular, but all health professions, can strengthen the health system by changing the way we train the next generation. This is a picture from that article from the Lancet, and it talks about the number of medical schools. Medical school is not the only indicator of quality of education, but there's an enormous disparity. And in many parts of Africa, it's really acute. When we started in 2003 in Ethiopia, there were 5 medical schools. There's now 35 medical schools. So it's also a story about a huge, huge expansion. This diagram shows the old or traditional model of thinking about education and what many countries around the world are trying to move to. At one time, the curriculum of a health profession school was almost completely disembodied from the society in which it was in. In fact, very often it would be simply transported across borders without any critical thought. Objectives would be created and assessments driven by that. The Lancet report calls for a system that many countries are adopting, which begins first with the health needs and the health system, then identifies the desired outcomes, and then, of course, the curriculum and assessment processes are created in service of those objectives. So to use an example from the Toronto Addis Ababa academic collaboration, you'll hear more from Clare about the first psychiatry program, but you don't simply transport a psychiatry curriculum from Canada or the United States and drop it in Addis Ababa. One has to understand what is the context of psychiatry, of mental health in this country in particular, understanding that 92% of people understand mental health to have to do with spiritual beliefs, for example. The history of holy water treatment and other models, very, very critically important. We're talking in countries around the world about moving from what was at one time a scientific kind of memorization, knowledge-heavy curriculum through the end of the 20th century into problem-based settings where education was mostly done in academic health centers, to now a much more systems-based approach where we think about competence in health professions as being driven by both the local and the global and set in the health system. And this means that the hospitals and clinics and community settings are as much a teaching focus as the big university. The final piece on this in the Lancet article, which I think is so important and has been really well illustrated and successful in this program, is that in the old system, we thought of education as helping people know a lot. What did you know? What could you memorize and reproduce on tests? Later, growing into a professional identity, so I'm a doctor or a nurse and I have a professional ethos. Now moving into the realm you'd call transformative, where the goal of education is to create change agents. And in TAAAC, we're very much aware that both the people participating in Addis, but also those in Toronto, education on both sides, one of the main responsibilities is not just learning about how to be a health professional, but learning about how to be a change agent in the system. So in summary, quality education in healthcare needs to be driven by social needs, inclusive of history and culture, supportive of individual and collective development, of equality and equity, focusing on creating leadership and change agents, and emphasizing the development of teachers. I'm just going to look at a couple of the first risks. Oh, no, this is exactly the moment where I'm going to switch to Dr. Clare Payne. So Keith, I think you may be wanting to take back over and recognize the one.
Thank you very much, Brian. That was a very eloquent description of the history behind the relationship between Ethiopia and Canada, and a very powerful commentary on the need to build sensitive, culturally aware, quality education that serves the needs of communities and nations. With that, it's a great honor to turn this mic over to Dr. Clare Payne. Clare, the floor is yours.
Thank you, Keith. And thank you, Brian, and thanks to everyone who's listening. It looks a little bit like we thought it out beforehand and then built a program around these great principles, but really it was more like stumbling into a mutual recognition of what UofT and Addis Ababa University would find helpful. And from that, we've solidified or developed more in the way of recognizing the risks and the benefits to both sides and trying to put in strategies to mitigate the risks. So the usual prevailing model, I think, is importing students or inviting students from low-income countries to high-income countries for training, which is much easier to do in some ways from our point of view, from a high-income country point of view, but from a low-income point of view, most students don't return. In the last 30 years, Addis Ababa University permitted 4,000 young, professionally prepared students to leave for graduate studies, and I think less than 100 came back. So it's devastating for a low-income country. We're very proud and rather surprised by the fact that by assisting training on ground, on site at Addis Ababa University, we have over a 90% retention rate of the people who are involved in the program. Brian mentioned again, rather easy for us, rather burdensome perhaps for low-income countries, the idea that we can export curricula from high-income to low-income countries with very little adaptation and with very little input from the people whose country needs and educational needs are not really considered. And it leads, certainly in psychiatry, we could see how much of a homogenization by exporting the DSM-4, you can, I mean, there are many discourses on this, but you can certainly see how individual cultural kind of expressions of distress and disorder get homogenized into one overall Western model. The other risk, in a way, is who goes, thinking of Brian's remarks on colonialization, how does one do this work, understanding or respecting local traditions or culture? I want to say, of the people I think who have not, we get the volunteers who go out, who are all U of T faculty, seem to absolutely love the experience of spending up to a month teaching graduate students. But of the people who haven't enjoyed it, often it's they've wanted passionately to teach evidence-based medicine procedures, but they'd find that there is no flow cytometry for hematology, or there is no particular instrument or technological necessity in the West for teaching evidence-based. So they feel like they're not doing the kind of job that they want to do. But I guess that's partly what attracts people to volunteering, because you do have to be flexible and kind of think outside the box with our colleagues there. So we developed, as Keith said, first of all, the Toronto Addis Ababa Psychiatry Project, because it was the first partnership between our universities where we went out there, we, U of T, went out there for 3 trips a year for 1 month each, with 2 faculty and a resident. We would base the training, the teaching, on the curriculum for the program developed by Addis Ababa, but we would kind of make a mash between the volunteers who came forward and the curriculum needed. The program is in 3 years. It takes 3 years to become a specialist in any of the medical programming there. And so we would have a sort of 3-year window to make sure we could pull together volunteers and develop local curriculum that fit the local needs. We were surprised that it seemed to work, and having found this model, Addis Ababa University came to University of Toronto and requested as much help in other programs as we could manage based on this model. We've had now, in the last few years, we've had between 80 and 100 people a year going to teach for up to a month. And our interest is in partnering with Addis Ababa University to help them build educational capacity and sustainability, mostly in graduate programs. Although when we started, I'm talking mostly about medical programs, but we've expanded beyond medical programs. But when we did start, there were no post-specialty programs like hematology or like some of the medical imaging programs. So that's where we focused. To illustrate that, there was 1 hematologist in the country. It's now 105 million people. There were 2 pediatric surgeons in the country. So one of the difficulties and the exciting things is it's hard on both sides when there's only 1 person who represents a whole discipline, but they're key for our partnering to develop capacity within their discipline. The curriculum is overseen and owned by Ethiopians. We try very much and respect the fact, as Dawit Wanda Magenya has said to us, our country, our problem. our solution, which is a wonderful way in which to work together. Academic credit and authorship, it's a kind of work in progress, but we very much feel that maybe some of the rules need to be changed around how we recognize the capacity to contribute educationally, which is different. There are different but reciprocal kinds of skills and capacities on both sides. We like this idea. Professor Whitehead developed this idea of us as invited guests. So we sit in the, the kind of front room of the house. We're not asked to go into the kitchen and look in the pots or inspect the plumbing. We're there at the generous invitation of our partners. And Brian's paper about how important it is to be reflective about what we're doing together and how, and the inevitable way in which we fall short of our aims, thinking particularly of colonialism, which is a very tough and sort of weekly challenge. Our first paper was about the Psychiatry Residency program that we shared, or we contributed to, so that they could open their first residency program in psychiatry. So it remains the oldest program now we've got about 24 similarly organized graduate and a couple of undergraduate programs. This was Brian and Lisa Anderman, Kevin Chopra were the first group. Kevin was the resident and Brian and Lisa were the psychiatrists who went out for the very first month of teaching in 2003. And this is a wonderful picture of some of those people are faculty, Ethiopian faculty, but some of them are also the graduating class of 2006. There's some pictures now of some of the programs that we are involved with. This is a lovely photograph of the TAAAC Emergency Medicine Residency Program. And it was one of the ones that we, with our Ethiopian colleagues, sort of started from scratch. When we started psychiatry, there were a few psychiatrists in the country, or on faculty, there was 2.5 full-time equivalent psychiatrists, but there were no emergency physicians or family medicine doctors in the country. Two of our main programs now. Family medicine, it's interesting, again, what Brian was saying, that on both sides, how this program seems to have attracted people or have assisted with that something else in contributors, so that on both sides, the people involved have gone on to have extraordinarily interesting careers and very senior positions. The first picture here is Jane Philpott, who of course is one of our ministers in the current government in Canada. So we have a program in family medicine from scratch, library, sciences, very interesting program in surgery, visually assisted thoracic surgery. So video assisted thoracic surgery. So you can do these tiny keyhole surgeries, which of course reduce infection, reduce length of stay, and are ideal for Ethiopia. We have PhD program in pharmacy. We have 4 medical imaging fellowships. This is our very exciting Masters of Health Professional Education, which hopefully will sort of form the basis of a cohort of people who are pedagogists, educators within the system. And this is just a list of all our programs. I won't repeat what you've already seen photographs of, but critical care we've just started, which is kind of exciting. We have 3 fellowships in medicine. Pediatrics, we have a new fellowship in ophthalmology. We have a new master's in psychology. We have occupational science and occupational therapy. the VATS program I mentioned. We are just about to begin radiation therapy, a program to develop radiation therapists. Dentistry is one of 2 undergraduate programs we have, the other one being speech language pathology. We have an exciting engineering program, and we've just started a master's in law, which we're excited about, and hopefully in the next few months, nutrition and program in clinical epidemiology. We have some publications. We want to continue to push forward on this front. Maybe between 64 and I think it's gone up to about 70 now. But there's lots to write about. This is our president of the University of Toronto, Professor Merrick Gertler, and Addis Ababa University Vice President, Chief Executive Director of the College of Health Sciences, Dr. Dawit Wanda-Magenya, who was one of our first graduates in psychiatry at Addis Ababa University, and who has gone on to be a very influential and important person in the country as well as in his university. This is our second. We just renewed our large TAAAC agreement between universities for the second time. So we have another 5-year agreement. Again, President Gertler on the left and President Tassau, University of Addis Ababa University president, current president. There's a lot more to say, but we'll end with, I'm going to show off and practice my rather bad Amharic with the expression Debirba Anbasa Yasser, which in very brief, Ethiopians are very good at writing these wonderful proverbs in four words, but it means that singly we're like spiders' webs, but together we can be strong enough to tie a lion. And in this case, we hope the lion is Talasu, the lion of education. Amasaganalo. That's thank you in Amharic.
Thank you very much, Dr. Payne. That was a lovely way to end your presentation and for filling out what Dr. Hodges started with. And I personally just want to thank you for all of the work you've done right from the beginning to set up a program that's helping so many people in Ethiopia. So before I go to the questions, if I may ask each of you one question. One is, I think, Brian, if I could ask you, how did you get the agreement and allow faculty to go to Ethiopia for a month period of time? And Claire, if you could perhaps share with us where the curricula came from across the different disciplines that you described. Did they come from Ethiopia or did they come from afar? So Brian, I'll turn it over to you first.
It's an excellent question. And with the huge number of faculty involved, 80 to 100 or more every year, you can imagine, I'm sure many listeners are thinking, my goodness, how is that possible? It's quite organic, actually, surprisingly. This is not a project that's ever had an enormous, large grant from anywhere. It has been successful in grants, but it's never been consistently funded with a big grant that, for example, buys out people's time. It's not done that way. So I think probably for each 100 people, there's 100 different ways of doing it. Some departments have done it through philanthropy, finding sources of funding to support it. Some of the funding comes from Addis Ababa, some from University of Toronto. For medical programs, physician practice plans are one source of support. I would say it's fair to say that almost all the time is volunteer time. No one is paid to actually do the teaching. What becomes more critical is the time back at home. If someone is in a salaried position, for example, physician or non-physician, other health professional, that time may need to be backfilled. And so the challenge is less paying the individual to go and do this. That's not so hard. It's making sure their home responsibilities are taken care of. So various different sources are used to do that. I think it's fair to say that one of Claire's main jobs is to spend hours and hours talking to all the people who are the bosses of all of these people to convince them of the enormous value of this. It's not lost on you probably that you've seen the president of the university in this picture. This is University of Toronto's largest international program now. So part of freeing up people to go is to articulate that this is not something on the side. This is not an extra. This is a major commitment of the university and its hospitals and partners.
Thank you very much, Brian. And it's underlying and enforcing that role. This is a very, very important endeavor by Canada's largest and one of the world's largest biomedical institutions. Claire, over to you with regard to the curricula.
The development of curriculum is the responsibility of Addis Ababa University. So when they want emergency medicine, for instance, they develop a curriculum in consultation with whoever they wish, but they develop it. Then we I'm too scared to take surgery as an example. Let me take psychiatry as an example. It would be up to our program to understand the gaps that can't be filled by the current faculty in country and supplement that with whoever is interested in volunteering. So it's a bit of an art of matching people who are very comfortable in an area with the needs coming from that particular department at Addis Ababa University. I wanted to give just one, if I may, example of the kinds of, I hope it demonstrates a sort of problem with that. So we will, in GI, there's a need to understand more about GI conditions. And so I remember two faculty going out to Addis to teach, and the textbooks are all in English, and they told us afterwards how much the English textbooks focus on ulcerative colitis and Crohn's disease. And these two experienced UofT professors went out and were trying to help the residents and fellows not miss the far more prevalent condition, which was TB of the peritoneum. So it's very easy to start to use textbooks to squish in diagnoses that are common for us and uncommon in Addis.
Thank you very much, Claire. I appreciate that. So the first question I'm going to pose back to you, Claire, and the second one, Brian, will be to you. First question comes from Dr. Eichbaum, and he wonders whether or not we're going to introduce a humanities course as part of the curricula that you are working on.
I think Brian wants to take that.
Okay.
It's a very interesting question, a very, very interesting question. I tell you, this isn't humanities, but one of the exciting spin-offs, in a way, from our friendship between the universities is Dawit Wondabagenya has started a young leadership program, which is open to all young faculty, and he has now in the second year of curriculum that they developed, and that they have invited speakers to run modules within it. I was present there last week listening to some of the lectures, and it's very much, it's not supposed to be humanities per se, but it pulls from far more than just medicine. It pulls in humanities, but locally. the local kinds of ideas, philosophies, even novels and poetry that influence the young leaders there.
I would just quickly add that the University of Toronto does have some links. Professor Michael Jervis here has a history program, for example, that's connected. There is a program in the traditional language of CUGH. There are extensions in this area. I think you'll detect that we're all health science people largely in the creation of this. So the first push was to build programs in health sciences, but we're actually hoping with the last visit of the president that if it's of interest to Addis Ababa, that really any department or program we have could become part of the partnership.
Totally.
Thank you so much. The next question is from Athena, and she is curious about whether or how you might consider measuring or evaluating the students as change agents as part of the teaching model. Is that possible?
Brian, why did
We're looking at each other. Go ahead, Claire, you start.
I mean, I don't know. Following trajectories has been very interesting, and seeing where our first graduates of even now, we've been going for 15 years, but still the people who are graduating still remain or are the leaders of their discipline, and they fan out into the other many universities to become the one faculty in whatever subject. So to some extent, just seeing how the program helps assist the country populate their own universities with much needed faculties is a kind of a measure.
This is a great question for educators in every country. Most of the international competence frameworks say something about graduates needing to be systems change agents. You can look at the macro. Of course, someone like Dr. Dawood is an outstanding example, and many of our graduates are very famous. But I think to Athena's question, educators are trying to think how we could show the competence of change. A great example is quality improvement in systems change. Both the Canadian and American frameworks and many others call this out as a competence. And I think there are ways to measure, to see, or to look at whether people are actually contributing to practice improvement, to public health issues as part of their training, and then once in practice. And that can be reinforced by performance reviews of practitioners.
Thank you. And another really interesting question has come up from Himali. Himali is dealing with the issue of retention that Claire, you mentioned a very powerful comment about training in country as opposed to training people in high-income countries. Himali asks, with regard to the retention rate is high, are trainees bonded in some way, or are they incentives provided them to encourage them to stay at Addis Ababa University?
There's no sort of change in there's no special change in their pay structures for staying. I think we don't really. We have some interesting hypotheses. One of the idea is that you start to develop a critical mass. So when you've got 10 hematologists, you can share cases, you can refer to each other, you can share the teaching, you can increase your research load quite considerably. So there's part of a sort of stickiness in once you get a bunch of people who are interested and committed. I think that most people want to stay in their own country. I'm not sure. I think education is so important to Ethiopians and to other people in low-income countries. They will leave if they have to get it, and then they fall in love with a Canadian and never go home. So.
There's a push and pull factor. Paul, Keith, you wrote a wonderful article, or you were cited in a wonderful article in the Walrus magazine in Canada some years ago, recognizing your own leadership in this area. And I know that people have called on Canada to be more attentive to the push and pull factors. I think to Claire's point, we have to be thoughtful not only of why people don't stay, but why they leave. And the literature would suggest that one of the main reasons they leave is that we make it very attractive for people not to return home. So partly paying attention to the ideas of poaching and brain drain and thinking about being fair about that. So in fact, building the incentives into the country rather than into our own country to bring someone out is a key factor.
Can I can I add one idea? When we do bring people here to train, or when programs do, for instance, I mean, our university or our hospital is opposite the Sick Children's Hospital in Toronto, an absolutely extraordinarily first-rate child's hospital. If you bring a pediatrician to study there, the technology that we have has very little relevance to the technology available in Ethiopia. So you almost train people to stay here because they can return feeling ill-equipped.
It's a very important point that you both made, and to ensure that the training is relevant to the clinical environment that someone is in is vitally important, and almost perhaps cruel to train somebody in an environment where they can't use that which is inaccessible in their own countries. Jill and Frank have a question with regard to, it's a bit of the same question, and it comes to a point that was made about the goal is to exit the training programs and enable Ethiopians to take it over. Can you share the successes that you've had so far in being able to exit from training programs and ensuring that the Ethiopians have taken charge of this?
Such a good question. It's a lot easier to get out because we form wonderful relationships with each other, and nobody particularly wants to stop. But taking the oldest program, psychiatry, we continue to have 2 one-month training trips a year, down from 3. And what they've chosen, instead of asking us, taking over themselves, what they've chosen to do is open a master's in psychology, a PhD in mental health. And by continuing to go, we have this, it's a slightly changed role where we're really interested in young faculty and in assisting them program more according to their own needs, and those programs are staffed entirely by them. So it gives more elbow by not stopping. We definitely have to change. It's silly to do the same thing whilst we are graduating excellent faculty. But I think the role changes a little bit, and we're doing a lot more research now in that program than we used to do.
Thank you, Claire. And I think aligned with that, a very intriguing question a lot of people have is, how did you manage to get the more recent governments in Ethiopia to financially support this endeavor? Can you share with us a little bit of the history behind, not the more distant history, but more recently, how the Ethiopian government came to support this wonderful collaboration?
I think I'm going to answer from a particular Canadian perspective. If you ask me how the Canadian government supports health professions education, we'd need a half an hour for me to explain the complex sources. And I think to some degree, Keith, it's a little bit similar. So there's not a simple budget line called support for this in the government. But that's because that's the way healthcare and education is funded. I would say there are some really strong advocates that have understood initially in the government, and then what's happened because of the capacity building that Claire is speaking about, we've built colleagues who influence the government. For example, when we opened the Masters of Health Professions Education program, the Ministry of Health itself sent a number of people to take the course. So they become our colleagues. I think the other thing that is actually wonderful in the global space is the sharing of resources across international projects. So for example, the Swedish SIDA, the Swedish International Development Agency, is a very generous funder, and some of those funds are not tied necessarily only to Swedish citizens, and some of that has been usefully used by the University of Addis Ababa. I mentioned as well that we have tried to educate change agents. So if you think about our graduates coming out of the program, what they do is they try to build capacity by influencing different government departments. And for example, going back to, we don't want to dwell on psychiatry the entire time, but the building of a national mental health policy, for example, or other national initiatives, health officers, etc., is really critical.
Thank you. And there's an extension of this, of your program. David's asking the question for many institutions who are interested in being able to do what you've successfully done, is what are the 3 or 4 key points you'd like to be able to provide for any institution, I know that's not many, for any institution that is interested in engaging in partnerships to do education and research from high to low income countries, or high and low income country partnerships?
I think we're going to share this. I'll start with one, and I think it's. I mean, I have very little experience in any other country apart from Ethiopia, but my sense is that each of these partnerships between high and low income countries are particular and specific. It's actually, there are some baked in principles, I think, which are transferable, but the actual specifics of government funding and university program development have to be very particular to the place which is with whom we are partnering.
I was actually asked that exact question on a recent trip. I was sitting beside a minister of health of another African country, and we had a long flight together, so he asked me exactly this question. I think, like anything, there's a number of factors that are important to begin with, but I want to go back to the very, very beginning. Claire will remember this, is how this started. I would give a lot of credit to a chair of our Department of Psychiatry at the time, Professor Don Wazelenki, who was a health systems person. And he actually gave us the following instructions. Claire had proposed this idea, and he sent a team there. And he said, find out the degree to which the people are ready for this, talk together, see what's on the ground. Of course, they made us teach, I think, the first day that we arrived. But what followed was a really thoughtful discussion about how this would fit into the strategy of our university, of the AA University, and how the two could weave together. I just would like to point out one other thing from that time. We discovered the Department of Psychiatry in those days had 115 international projects. And Professor Wazelenki said, there's no way we can do 115 international projects well. We need to have at most 1 or 2. We need to have some objectives, goals. It can be iterative, it should evolve, but it needs to be evaluated and measured and concentrated. And here we are 16 years later, I think still trying to do that. So perhaps the piece that I would add is it's not a one-off. Too often we see people show up, drop something, funds, programs, leave again. It's really a long commitment, and so it has to serve both partners very, very well.
Sorry, can I add? Yeah, it is perhaps easier to think in terms of technology providing online training programs, and there's I mean, as yet, Ethiopia is not able to sustain that kind of educational partnering using technology alone. But I think we all believe that the time people spend, each of the programs has one kind of mid-career level lead. And that person goes out with each trip, and no matter how brilliant and committed the volunteers are, it's really hard to land up in another country and start on Monday morning without somebody who can accompany the group and just settle them in and make the introduction. So I think that has been, it's expensive in time, but I'm not sure that there are many substitutes for that. So I think time and depth, in a way, of relationships has been a useful idea.
Great. We only have about 6 minutes left, and I want to get to one last question before I hand it over to both of you for any last comments. But this is a very important one. we know that there are huge human resources deficits within cities, but that deficit is amplified significantly in rural areas. So this question is, can you share with those online how you've been able to seed training programs in rural areas and seed and retain human resources in those underserviced areas?
So let me begin, because before I personally got involved with the Addis Ababa project, my job was to create a program for the north of Canada. It's remarkable to me how many similarities there are in whether it's recruitment and retention or model development or some of the issues we've talked about in technology, etc., between the rural and remote areas, even in Western countries. So I think the message there is that there's a lot that is very transferable. Claire in a moment could speak perhaps about rural and remote areas in Ethiopia itself. But I wanted to point out that what works in Canada, United States, Sweden, other places that have very large underserviced rural areas is not that dissimilar, in that you're never going to expect to have a full complement of all health professionals in rural areas. You need a referral system, you need a community-based system, and you have to convince the core, the big cities where a lot of the resources and money are, that they need to care about the rural and remote areas because it's an integrated system. So I actually think this is one of the areas where we're united across low and high income countries. We have very, very similar problems of underserviced in many, many countries of the world.
Thank you very much. Go ahead, Claire, please.
Sorry. One of the clever ways, I think, in which the Ethiopian government addresses this problem is that universities are now really extraordinary explosion of the numbers of universities in the country. They will send somebody to do medicine, for instance, at Addis Ababa University, and maybe to do another specialty and subspecialty. And then that person is required to return to their home university, which may not have a department or even one specialist in the area. So there's a natural way in which the country is addressing this, at least to increase the faculty in the many new universities. The other example, I think, which again the government of Ethiopia is quite spectacularly, doing extremely well in, when you look at medicine, it's always been specialist heavy, or very few specialists, but now they have a health extension program where they've got 40,000 grade 12 people who have had a year training, and they're more widespread than primary health care. So it's beginning to be a sort of pyramid of these health workers provide prophylactic training and stats management in the villages. Then you get primary health care, which is a large non-MD. It would be staffed by a nurse and health officer. And then you get general hospitals. Then you sort of this pyramid is being slowly built. Our direct relationship between the pyramid at the bottom level, we've had some very we've had a nice grant from Grand Challenges Canada, where in psychiatry we've started to integrate mental health services at the primary healthcare level, which was never there previously. It's slow, steady work, but the government, as Brian said, the strategy of mental health in the country is pushing for this access more broadly in the country.
Thank you very much, Claire. And I'm afraid we've run out of time. And I would just like to, on behalf of all of us at the Consortium of Universities for Global Health, really thank you, Dr. Brian Hodges and Dr. Clare Payne from the University of Toronto. You've given a very sensitive but important and powerful description of the Toronto-Addis Ababa collaboration that through the years is really working with Ethiopia to address their significant human resources deficits. And I think there are a lot of lessons from many institutions that can take from what you have done. And I would encourage everybody to be able to go to the collaboration, to take a look at what they've done online. There's a lot of lessons to be learned from there. I'd also like to thank Karen Lamb and Dalal Najjar for putting on this particular webinar. I would encourage you to take a look at the webinar, which will be online at CUGH.org, and attend our conference, which is coming up March 7th to 10th in Chicago, because there over 1,800 people from around the world will get together to address some of the compelling challenges that we've heard today and beyond in global health. So thank you for attending this webinar, and we look forward to seeing you next time.